You're now listening to the Adiel Gorel Show. Each episode, I'll bring you the latest news from my discussions with top health and wellness experts so that you can bring yourself into better health. Today, on the Adiel Gorel Show.
What is happening is that slowly the entire world of spine surgery moves in the wrong direction. So I always tell people that, the victims are not just the people who receive that product. The victims are much broader. It's the entire people with back pain actually are the victims because the whole thing is shifting in the wrong direction.
Hi everybody, it's very nice and beautiful to be back here with you on the show. And it's very exciting. We have Dr. Ardavan Aslie with us. He's a spinal surgeon. And Dr. Aslie, welcome to the show.
Thank you. Thank you for having me here. I'm very excited.
So, can you talk just a little bit before we delve into your specialty? Can you talk a little bit about what you've been generally observing in the medical field? Then we'll go to your specialty.
Sure. In what aspect? Like what I see in my...
Just some things. We can start with your specialty and things that you've seen, and maybe from there we can extend it if there is an extension to be made.
Sure. I really can't comment about other specialties because I'm so super specialized in my field. But what I've observed in my field is that, and of course I don't want to generalize it. There's always some bad apples that ruins everything. It doesn't mean the whole patch is bad. One bad police officer doesn't mean the entire force is bad.
No. I'll be the first, to tell you. My main business is nationwide real estate investing.
Yes.
In the real estate investing field, you have many bad apples, good apples, rotten apples, beautiful apples. So
Right.
It's the same in every field.
Right. But what has happened in the world of spine surgery is that, let's say a company comes up with a product. Then what they do, they approach a spine surgeon that is always a very famous spine surgeon from a very well-reputed institution. What happens is that what's supposed to happen doesn't happen. But what happens is that surgeon starts writing papers that are very positive about that product. So we all start using it. And then 10 years later, when we find out the product didn't work, nobody says anything. Everybody just moves on to the next product. And then, but what is happening is that slowly the entire world of spine surgery moves in the wrong direction. So I always tell people that, the victims are not just the people who receive that product. The victims are much broader. It's the entire people with back pain actually are the victims because the whole thing is shifting in the wrong direction. And it's not just me saying it. In 2020, I walked into my office and I have a journal, a spine journal, which is our Bible, basically. Every spine surgeon has, subscription for that journal. The lead article, this is exactly what the lead article said, word for word. Undisclosed conflict of interest is prevalent in spine literature. It's our journal is telling us that our literature is tainted. That's just crazy. Nobody's doing anything about it. And it's come to a point that is so bad that we just don't know what to tell our patients. One of the biggest examples is a surgery called disc replacement surgery. Normally, spine is a bunch of bones that are stacked up on top of each other, separated by this cushion, a cartilage, that we call a disc. Sometimes it can get injured and cause pain. So the treatment for it is the traditional treatment is to remove that and fuse the two bones together. We came up with this idea that maybe we don't have to fuse. So we came up with this therapy that actually we have a prosthesis that can move. So you take that disc out, you replace it with this prosthesis. Well, the first batch of papers that came out was very promising. And every time you see the literature, you got to see who wrote the paper. If the paper is by people who are connected has financial connection to the institution, they paint this rosy picture that they're just so good, the best thing, and will never do another surgery again. And then you see papers that are published by independent organization, and they say this kind of works, but sometimes doesn't work, and it's so much different. So we don't know what to tell our patients. And that's really bad. And the state of spine surgery right now, after what I found out, it's dire, and something needs to be done. It just cannot go on like this, basically.
Okay, but there is the freedom to express, let's say a surgeon such as yourself used a device and your experience showed it wasn't that good. You certainly have the freedom to put out a paper or to report that fact. Nobody is going to try to stop you or censor you, right?
Correct.
That still exists.
Correct. Yes and no. There are a couple of things. Yes, there is certain things that come up that are experimental. So it just recently came up, let's say. So so those we don't know really work or it doesn't work. Some people believe in it, some people don't believe in it, and that's a freedom. Okay, so that's something new stuff in a way. But then the whole, I wrote a book about this thing, but then there's other techniques that has been ingrained in the world of spine surgery that become what do they call it? Practice, standard of care. That's the word it is. Those, unfortunately, you don't have a choice, and that's my predicament. That's my problem. I found out some issues that we'll discuss later that it was like, wow, shocking. And the first thing that the patients or people ask me is like, well, if you don't like it, are you still using it? Why are you using it? Now you know this. I said, well, because that's the standard of care. If I do a surgery.
Okay. I would like to go a little deeper into the definition of standard of care. I mean, it's a very familiar concept, but in your domain, in your world, I would like to see what standard of care is, if you can define it, and then if you can explain what makes it so that it can't be challenged.
Okay, so let's start with the problem. The normal surgeries that we do, the common surgeries that we do in spine surgery is what we call a fusion surgery. So we started doing these surgeries around, let's say, 60s and 70s, when we had X-rays. I always tell people that it wasn't until invention of the MRI that we were able to look at these discs and see what's happening to them. So the whole world of spine surgery is actually a very new field. But let's say in 50s and 60s, we had X-rays, and we see that disc is deteriorated. So we said, okay, well, let's fuse the vertebrae, eliminate the pain generator, and hopefully this will turn into a patient that we can get rid of the pain for him. So we started doing those surgery, and the fusion surgery, when we first started, was a very crude surgery. You would expose the bone, the two vertebrae, and you put bone chips between the two bones, and you're hoping that these bone chips will turn into a solid bone. Well, what happened is that in about 25%, so 1 out of 4 patients, it didn't turn into a solid bone. Then we ended up, it didn't heal, the fusion didn't heal. So we ended up with a byproduct or complication we call non-union. Well, that's really bad, because when you end up with a non-union, pain is even worse than the original pain. So you have to do the same surgery almost over and over and hoping that one of them will basically fix it. Well, right around mid 1980s, like 1985 or so, a group of surgeons in France figured out a way to put a large screw, insert a large screw into the vertebrae, and presented that in the world of orthopedic surgery. I'm sorry, American Academy of Orthopedic Surgery at late 1980s. This screw gets inserted from back to front. I have an example of it right here. Gets inserted from back to front, and it gets inserted one on each side. So once they get inserted, the other end of the screw has a tulip that it can accept a rod. So what you do, you put as many screws as you need levels to be fused, and then you connect them with a rod on each side. And that way, what we've done, we've immobilized the section so the fusion can take place better. And this knowledge came to us from orthopedic surgery. We are orthopedic surgeon. There are two ways of becoming a spine surgeon. One is through orthopedic surgery. The other one is through neurosurgery. So you can become an orthopedic surgeon or a neurosurgeon and then start practicing as a spine surgeon. I went to the orthopedic route. When I did my orthopedic residency, bulk of the surgeries that I did was fracture fixation. I mean, fracture fixation was a big thing in orthopedic surgery. And the concept of fracture fixation was a concept we call rigid fixation. So in 1960s, we figured that we don't have to cast the patient. If we cast the patient, then the cast gives them kind of a contractures in a way. So what we did, we opened up the fracture, we put these plates and screws, and we secured the two ends of the bone together in a rigid fashion. And we saw that bones healed together very well. We didn't have to cast the patient, we didn't have to redo the surgery, and it worked great. So when we saw these screws coming out in late 1880s, we said, this is what we've been waiting for. And then we started using those screws. Well, this comes a problem. Well, let's tell the whole story then. So by 1990s, there was a significant controversy about the use of the screws. First thing were the neurosurgeons. Neurosurgeons were saying like, well, wait a minute, what is this? We don't know about this. And orthopedic surgeons were saying, no, we know this works. We know this is how you do it, and this is how you should do it. Well, the results were not good. And actually, there were about 7,000 lawsuits against the manufacturer of the screws, a company called Medtronic. The lawyers not only sued the manufacturer, but they actually sued the surgeons as well. There were about 500 lawsuits against American Academy of Orthopedic Surgeons and North American Spine Society. Then, by 1993, a surgeon called Dr. Zdeblick published a paper in 1993 that said these screws work beautifully. They work great. They are better than anything else we've ever had. And based on that paper, we started using these screws. By 2000, let's say, right around late 1990s and early 2000s, use of these screws as an adjunct to fusion surgery became the standard of care, meaning that if you went to a spine surgeon, especially orthopedically trained, you got the fusion, you got these screws automatically. To a point that if you had a fusion and the surgeon didn't use these screws and something bad happened, let's say the patient went to see another surgeon, the other surgeon, the first thing they would point out is like, that guy didn't know how to put screws in or is not a good surgeon, and that's why your surgery failed, basically. So everybody started using these screws. So from, let's say, 2000s, let's for the sake of argument, from 2000s, we all started using these screws. Well, here comes me around 2015. As I said, these screws get inserted into the vertebrae. Well, the bone, the vertebral bone, is not a solid block of cement. It's not like like a wood. It's like a shoebox. Outside bone is very dense cortical bone. Inside bone is a spongy bone. We call it cancellous bone. So when these screws get inserted into the vertebrae, they're actually they're getting their purchase from weak spongy bone. Well, when we get older, this spongy bone gets affected by aging and osteoporosis. So right around 2000s or so, 2005, we saw that, oh my God, what are we going to do with the aging population? These aging population coming toward us, we're seeing them, and these screws keep pulling out. We have to take a patient back to surgery over and over and over, do the same surgery. And then when you repeat the surgery, you repeat the same surgery, except you use bigger screws. So almost like you go do the same surgery over and over, hoping that one of them basically will heal. And, a good chunk of the patient kept going surgery after surgery. So right around 2015, I said, I need to invent a device that is good for aging population. So I invented a device, to make the story short. I invented a device, and it's a flat plate that sits against the lamina. Now, lamina is a cortical bone. It's the roof of the spinal canal. So if you look at the vertebrae, hold on, let's see, I had it. So if you look at the vertebrae right here, you can see that the vertebrae is composed of body and then the two laminas that cover the top of the spinal canal. Those lamina is a flat bone and it's a purely cortical bone. It's one of the strongest bones in the body. So I invented a device that was a flat plate that sits against the lamina and uses composite straps to wrap around the lamina, and it tensions like a zip tie. Once you tie it down, there's a clamp that's built to the base of this tool loop. There's a screw that you turn, and the clamp clamps the straps, and this holds on to the vertebrae without penetrating the bone. So I presented this to Congress of Neurological Surgeons in 2015, and I won the Innovation Showcase. So I'm legit. So my device won the, Congress of Neurological Surgeons. Well, here comes the problem. Then I started developing further and further because it was still and still is in the prototyping stages. I had a problem with it. Then I said, let me look at the screws, see how they solve that problem, or if they have the problem or not, what's going on. And that's when I start digging deep into the literature, and what I found out was frightening. I mean, literally frightening. And this is what I found out. One thing is that the problem that I had with my device existed in pedicle screws as well, except nobody talked about it, nobody recognized it. So when I looked at the literature, I found that, okay, we went earlier, we said that in 1993, Dr. Zdeblick published that paper that basically became the gold standard of everything we do today. Okay, so right around 1997 and 2003, 6 multi-center, multinational papers came out looking to these screws, and they said these screws don't work. They do not increase fusion rate. They do not improve outcome. When I say that, I was like, wait a minute. What is going on here? I said, well, let me look at that paper in 1993. Let me just dig up a little bit more about Dr. Zdeblick, see what's going on. Well, I found out that at that time, when Dr. Zdeblick published that paper, there were 7,000 lawsuits against the manufacturer. After he published this paper, starting in 1996, he started getting paid from the company that manufactures this. I was like, wait a minute, that doesn't sound right. So by 2003, he had gotten paid $34 million. Right. And just when you think things cannot get worse, it does 10 times worse. So by 2004, the same company, Medtronic, put him in charge of another important study, a study for bone graft substitute. Every time you do a fusion, you need to get bone chips. Well, where do you get those bone chips? You have to get it from somewhere else. Well, the problem is, like, every time you get it from somewhere else, that somewhere else becomes a problem. So we wanted to avoid adding problems to the problem we already have. So Medtronic came up with a product. It's a hormone that we all have. It when you break your bone, it gets excreted and you heal the bone. So they were able to isolate that in the 1960s, and it comes as a product in the sponge. They call it BMP, bone morphogenic protein. So when this came out, there was a big thing in spine surgery because we were like, oh my God, we don't have to get bone graft anymore. But then the question was, does it work? So Medtronic put him in charge, put Dr. Zdeblick in charge of this study of BMP. Well, he published the 2 papers, one paper in 2004 specifically. This time he got caught falsifying his results. Not only that, it was concluded by United States Senate. There was an investigation by United States Senate. United States Senate concluded that that paper that Dr. Zdeblick published in 2004 was not written by him, was written by the company. So I was like, wait a minute, what is going on here? Let's go back and look and see what's going on with that paper in 1993. Well, I knew that there was a problem with that paper, but I said, let me investigate a little bit more. The first thing that I noticed was that paper that was published in 1993, Dr. Zdeblick, was published as a preliminary report. I was like, well, where's the final report? I spent 2 years looking for the final report, and I couldn't find anything in literature. So eventually I was talking to one of the professors from Midwestern universities, and I said, I can't find, where is the, he goes, oh, that study was abandoned in the middle, was never finished. I was like, really? I mean, that's just crazy. Wait a minute, that doesn't make sense at all. So this is what we have right now in the world of spine surgery. We have a standard of care that we all do it. The only evidence for it that it works is one paper that was unfinished by an author that's been proven to be a cheater, basically. So
Okay, but I'm gonna challenge you here.
sure.
If that's been used since '93 or '4 or '5, and now we're talking nearly 30 years later, and let's assume it does not work well, wouldn't there be hundreds, if not thousands, of surgeons from all over the world saying, hey, stop, it doesn't work, it doesn't work? How did it remain the standard of care?
That's the big question. That's the big question that I had to answer for 3 years. It took me 3 years to answer that very same question. I was actually questioning our core. I was like, is there a conspiracy going on? Is there a payment in the back door? Are we crooks? Are we become like, basically you become a surgeon and then you become a crook? And I found this out, and this is the answer. So we practice based on what we learned, what we were trained, basically, right? So the fact that I'm saying that every evidence so far that's published says that these screws don't work, and there's one questionable study, and everybody latching on that one study that says, this is it, we got it. Everybody knows about this. If you go to surgeons that they know research, they're in the academic positions, they will tell you that, yes, you are right. And every time I go to the lectures, they talk about this. They said, yes, we know that we haven't been able to show with research that these screws work, but we will in the future because we know it works. And there are two things that I'm going to explain here. My reaction to them is, and I've talked to them about this, I said, every time you fail to show that something didn't work, every time you fail to show that something works, you have just shown that it didn't work. This is not two separate events. When you fail to show something works, you just showed that it didn't work. So we've over and over, repeatedly, we've shown that these screws don't work. And then they say, well, we will in the future. I'm like, wait, that's a definition of insanity. You're doing the same experiment over and over to expect a different answer? That's crazy. So I had to answer that question. I mean, what is going on? When I go to research and people say, well, have you brought this up with the professors? I said, absolutely. I have brought it up, and I get the same answer that I told you. And the surgeons tell me that, I can't do my surgeries if I don't have the screws. What are you talking about? They want to just kill me. And I had to answer this. What is going on here? And this is the answer. We became orthopedic surgeons first. In that 5 years of practice, they beat it in our head that the key to bone healing is a rigid fixation. So you do 5 years of orthopedic surgery and your exposure to spine is very minimal. Very minimal. We all know about this. And then you do 1 year, just 1 year of spine surgery, and then all of a sudden you go out there and practice as a spine surgeon. So we learned what we learned from orthopedic surgery. We applied those concepts to spine surgery. And I'm here to tell you that we should have never done that. Spine surgery was never meant to be a subspecialty of orthopedic surgery. There is nothing in orthopedic surgery that will make you a better spine surgeon. I'll explain to you. Very simple explanation. The concept of rigid fixation works in general orthopedic surgery for one reason. Because if the fracture is in extremity, like arms and legs, you have the option of eliminating gravity. Like when you do the upper extremity, well, the patient's in a sling. In the lower extremity, you put the patient on the crutches, so you don't let them walk on it. You can't do that when it comes to spine. The second that you cannot hold the patient in air for like 3 months at a time. So the second that guy gets up, the patient gets up, that construct is under constant stress. So what you have to do is the same concept that you build high rises in an earthquake zone in San Francisco. We tried to make it stiff and it didn't work. So what you do, you make it flexible, not flexible, but reactive. So when the earthquake comes in, it doesn't crack and fall and burst into pieces. It flexes and dissipates the energy. I remember I was about 2 months ago, I went to a field trip with my 11-year-old fifth grade daughter. And the camp teacher was telling the girls about the suspension bridge and the earthquake zone. And she kept saying that, remember kids, flexible is stronger. Flexible is stronger. And I said, oh my God, I wrote a book about this. So, so what I'm trying to tell you is that, so when it comes to spine, the concept of rigid fixation does not work. You have to have a new set of um, instruments that can dissipate. So I call it reactive rigid fixation. So it's not flexible, but it can give, it can move, and it can dissipate it. So when the patient does something or maybe fall down or something like that, it doesn't cut out and break out of the bone and just basically fail completely. That's the reason. So basically, the analogy is like going from quantum physics, going from Newtonian physics to quantum physics. If you want to build a house, you can use Newtonian physics. But if you want to build a laser or shoot a spacecraft to space, you have to use a total set of physics called quantum physics. Newtonian physics is not going to work. That's the same thing. What worked for orthopedic surgery, we can't use that for spine surgery. So the problem is our training from the very beginning. We went in the wrong direction.
All right, so I have a question
Sure.
for you. You said that spine surgeons come from two schools, so to speak. The orthopedic school, which is your background.
Correct.
And the neurological school. Are those people from the neurological, school, are they better equipped to do it right, or is it the same problem or a different problem of the same sort?
Okay. This is how it goes. And that thing that you just mentioned, this question that you just mentioned, I have worked on that for the last 5 years. I've thought about that for the last 5 years. In orthopedic surgery, you learn the wrong biomechanics. In neurosurgery, I just can't see brain surgery, they go over any biomechanics. But this is the situation. When I explain this to neurosurgeons, they absolutely understand what I'm talking about because their brain is not clued. It hasn't been hammered into their head that the concept of rigid fixation has not been hammered into their head. Because I'm an orthopedic surgeon, I know what they do in orthopedic surgery. So that hasn't happened to them. So their brain is much more fresh, much more acceptable of this new concept. But when I talk to orthopedic surgeons, when I question this group, they want to just kill me. I swear to God, they just like, how dare you even saying that? I'm like, this is not logical. This is just crazy. So that's why I had to say. So what I'm saying is that it's not both. I mean, spine surgery was never meant to be a subspecialty of orthopedic surgery or neurosurgery. It needs to be specialty of its own. And 1 year is not enough at all. You need at least 4 or 5 years to really understand what you're doing.
Okay, so stay tuned for part 2 of this interview. Thank you for joining us today. I know you love what's coming next in part 2. Be sure to click the subscribe button for more videos.